welcome back to Not So Complicated, and today we are doing a session on endocrine pathology. We have completed our general principles of pathology, respiratory pathology, cardiovascular pathology, gastrointestinal, and then renal and hematology and oncology. Now we are tapping into endocrine pathology in almost 3 to 4 sessions probably, and this session will be of almost 30 minutes. So let's see how much we finish, right? So without further delay, we are starting from syndrome of inappropriate antidiuretic hormone. So actually what it is obviously it is named at antidiuretic hormone, and diuresis actually means the fluid excretion out of the body is diuresis, right? And if there is no diuresis, like antidiuresis, that is antidiuresis. So there is retention of fluid in the body, right? So it is characterized by excessive free water retention because there is no control in antidiuresis, right? So there is excessive free water retention that is causing hypervolemic condition of the body, right? But it causes euvolemic hyponatremia. How is that? We'll talk about that. In initial decompensated phases, that there is a volume overload in our body due to this syndrome, there is hypervolemia, right? Increase in blood volume or fluid volume. So since there is same concentration of Na+, that is sodium, but fluid volume is increased, Na+ concentration is now diluted, thus it creates false hyponatremia condition in earlier phases. Like hypervolemic hyponatremia will occur, but later on body tries to compensate this water retention condition by inhibiting RAS system, decreasing aldosterone, also increasing ANP and BNP, that is atrial natriuretic peptide, brain natriuretic peptide. They are actually released when cardiac muscle are stressed due to fluid overload, and that will lead to increased sodium secretion. Not only sodium secretion but also water secretion, right? So this water secretion will finally compensate the body to the euvolemic condition, but hyponatremia will occur because with water also sodium are getting excreted. That is why in compensated phase euvolemic hyponatremia happens, right? So urine osmolality is greater than serum osmolality due to sodium loss in the urine. Also, euvolemic hyponatremia is the reason for euvolemic hyponatremia. The treatment is fluid restriction because obviously there is antidiuretic happening, that is first line, and salt tablets because sodium is getting lost in the urine, IV hypertonic saline in the severe cases, diuretics to excrete the fluid, and also ADH antagonists, direct antagonists can be used like conivaptan, tolvaptan, and demeclocycline, right? So that is how we do it. So SIADS causes include, what are the causes for this? Healed up water, right? It is a mnemonics. Healed up. H is head trauma, as in CNS disorders. Is ectopic ADS like small cell lung cancer. There is paraneoplastic syndrome happening. We will talk about paraneoplastic syndrome in detail later on. In paraneoplastic syndrome, in small cell lung cancer, ectopic ADS is released, and exogenous hormones like vasopressin, desmopressin, oxytocin, and lung disease, and also drugs like SSRIs, carbamazepine, and cyclophosphamide, they lead to SIADS, right? So this is the pathophysiology in figurative manner. Here, posterior pituitary actually has the storage of both ADS and also oxytocin, right? Hypothalamus secretes the ADS to posterior pituitary, and posterior pituitary secretes ADS, right? So that is this is secretion, this is storage, right? So SIADS actually stimulates the release of ADS, but ADS antagonists, lithium, nephrogenic, diabetes insipidus, they all inhibit ADS secretion, right? So that is what it happens. Okay, let's talk about primary polydipsia and diabetes insipidus. There are types of diabetes insipidus, that is central diabetes insipidus and nephrogenic diabetes insipidus, right? So let's talk about it. It is characterized by production of large amounts of dilute urine with or without thirst. There can be thirst or without thirst, right? That is the symptom. And urine specific gravity is less than 1.006. Urine osmolality usually less than 300 milliosmol per kg. That happens. And central DI, that is central diabetes insipidus, may be transient if damage is below hypothalamic median eminence or in the posterior pituitary. So basically in central DI, the etiology is on brain region, right? And also ADS in hypothalamus can still be secreted systematically via portal capillaries in median eminence. So central DI, also known as arginine vasopressin deficiency, nephrogenic DI is also known as arginine vasopressin resistance. So what actually happens in central DI is that there is no secretion of arginine vasopressin. There is no secretion or little secretion, but in nephrogenic DI, there is normal secretion of vasopressin or ADH, but there is resistance of ADH in the nephrogenic receptors like B2 receptor mutation, right? Also caused by drugs too. Let's talk about the differences. So what is primary polydipsia? Polydipsia is actually increased thirst, so increased water intake. So excessive water intake happens, that is polydipsia. And in central DI, there is decreased ADS release. There is ADS resistance with normal ADS release. I have talked about it earlier. And the causes of primary polydipsia is psychiatric illness, obviously. Hypothalamic lesions affecting thirst center can occur. And serum osmolality is decreased, obviously. Why is that? Because there is increase in blood volume and or fluid volume that decreases serum osmolality. ADS level is decreased or normal. Why decreased? Why decreased? Antidiuretic hormone, because diuresis is inhibited in this case, right? And that can happen in this case also, but it is most probably normal, right? And in a water restriction, significant increase in urine osmolality, that is almost 700 milliosmol per kg, right? And desmopressin administration, we don't have to do that. Treatment is water restriction. That is it. In water restriction, the osmolality will increase almost greater than 700 milliosmol per kg. Let's talk about central DI. The causes are idiopathic brain injury like trauma, hypoxia, tumors, surgery, infiltrative diseases too. And serum osmolality is obviously increased in this case. And then ADS level are decreased because there is no secretion, no change or slight increase in urine osmolality. And then significant increase in urine osmolality in desmopressin administration. So in water restriction, there is no change or slight increase in urine osmolality, but in desmopressin administration, there is significant increase in urine osmolality because desmopressin is just an analog of vasopressin, right? That is why. And treatment is desmopressin in this case. So in nephrogenic DI, the causes are hereditary. B2 receptor mutation. B2 receptor is actually present in the principal cells of proximal tubules, and they actually form the aquaporin channels, right? So drugs, example lithium and demeclocycline, hypercalcemia, hypokalemia conditions can affect this nephrogenic diabetes insipidus. Serum osmolality is increased in this case. In both cases, serum osmolality is increased. ADS level is normal or increased because it can be a reflex or compensatory mechanism of the body. That is why it may be increased in some cases. But in water restriction, there is no change or slight increase in urine osmolality is there. And in desmopressin administration, there is minimal change in urine osmolality because obviously there is already enough vasopressin to act on, but there are no receptors or receptors have resistance to this vasopressin, right? So treatment is we have to manage the underlying cause, low solid diet and HCTH, amiloride, and then indomethacin. These are the drugs that we can use, right? So there is no water intake. We should not take water intake for 2 to 3 hours, followed by hourly measurements of urine volume and osmolality as well as plasma sodium concentration. So in B, here in B, desmopressin, that is ADH analog, I talked about it earlier, right? So it is administered if serum osmolality is greater than 295 to 300 milliosmol per kg, plasma sodium is greater than or equals to 145 milliequivalent per liter, or urine osmolality does not increase despite increase in plasma osmolality. These are very high yield points. You just have to remember this. And then let's talk about other things. Okay, that is this. To summarize, this is it. There is decreased in ADS release, there is a normal ADS release, but ADS resistance is there, and there is excessive water intake due to psychiatric illness, hypothalamic lesions affecting thirst center, right? So the treatment, there is desmopressin is treatment for central DI because it is ADS analog, and here are the treatment like hydrochlorothiazide, acetyls, amiloride, and indomethacin, right? That is it for primary polydipsia and diabetes insipidus. Let's talk about hypopituitarism. So under secretion, hypo is always under secretion, right? So under secretion of pituitary hormones due to there are various underlying causes. There can be a hypothalamic disease, that is mass lesion, radiation, or infiltrative lesions, and also pituitary surgery. Pituitary disorders like mass effect due to non-secreting pituitary adenoma or craniopharyngioma can be the causes. And empty sella. What is sella? Sella turcica is actually the region where pituitary gland lies, right? So empty sella is congenital absence of pituitary gland that can happen. And in Sheehan syndrome is ischemic infarct of pituitary following severe postpartum hemorrhage happens. So what actually happens in Sheehan syndrome is that I want to talk about it in detail. So in pregnancy, what actually happens is there is fluid overload or hyperdynamic state of circulation, right? So to compensate the hormonal need for pregnant mother and the baby, pituitary gland enlarges, right? It hypertrophies. And just when there is postpartum hemorrhage, severe postpartum hemorrhage, obviously this enlarged pituitary gland is has a very high vascularization in here. It needs a lot of blood, right? So there is severe postpartum hemorrhage. This blood vascularization system won't be able to provide the blood that is needed to the hypertrophied pituitary gland, and that causes ischemic infarct in the pituitary. That is Sheehan syndrome. This is the pathophysiology of Sheehan syndrome. This is very high yield question for USMLE step 1. You have to note it down right now. Okay. Pregnancy induced pituitary growth, that it increases susceptibility to hypoperfusion and usually presents with failure to lactate, amenorrhea, cold intolerance, that is anterior pituitary hormones mainly affected. The treatment is hormone replacement therapy like glucocorticoids, thyroxine, and sex steroids, and human growth hormone. We can use that. Okay, let's talk about acromegaly. Acromegaly is actually the increase, that is excess growth hormone in adults, typically caused by pituitary adenoma. So pituitary gland is the master gland of our body, right? It controls the almost all other gland secretion. That is why if there is pituitary adenoma, that can impact the other gland secretion. Just like in this case, there is excess growth hormone secretion in adults that is leading to acromegaly. Let's talk about it. What are the findings in the acromegaly? It has large tongue with deep furrows, frontal bossing, coarsening of facial features with aging. Here you can see the figure. Frontal bossing is the slightly raised forehead, that is frontal bossing, and there is large tongue obviously with deep furrows and coarsening facial features like this, coarsening, right? And there is deep voice. Diaphoresis is excessive sweating, and hypertrophic arthropathy can happen. Also, impaired glucose tolerance, that is insulin resistance. Diabetes is a very much commonly presented problem in acromegalic cases. Hypertension and LVH, HFpEF, most common cause of death. These are the lesions that we have to remember. So LVH, left ventricular hypertrophy, and HFpEF, this is homework for you. EF is ejection fraction, that the previous one you have to see. Okay, in children, if there is increase in growth hormone, that causes gigantism, that is increase in linear bone growth due to unfused epiphysis. But in adults, what actually happens is there is fused epiphysis, so the growth is in metaphysis, right? And also in diaphysis. The acromegaly in adults, gigantism in juniors, obviously. You don't have to have the mnemonics to remember a simple thing like that. And the diagnosis is, we have to do the serum IGF-1 analysis. It is increased in this case. Growth hormone levels unreliable as they fluctuate throughout the day. Failure to suppress serum growth hormone following oral glucose tolerance test. Also, pituitary mass can be seen in brain MRI. So treatment is pituitary adenoma rejection. This is not the sole cause of acromegaly. There can other causes that increase growth hormone in the body. But if there is pituitary adenoma increasing growth hormone in the adults or children, so we have to resect the tumor, right? So if it is not cleared, we have to treat with octreotide, which is somatostatin analog, or pegvisomant, that is growth hormone receptor antagonist, or dopamine agonist like cabergoline. These are the treatment if the rejection does not work, right? That is how acromegaly is done. Let's talk about thyroid gland. So probably we'll try to finish this thyroid gland, hypothyroidism, hyperthyroidism, and the other lesions that are associated with this. We'll try to finish. If I don't get tired speaking alone, because I'm just ranting here, right? Let's just talk it. Okay. Let's begin from hypothyroidism versus hyperthyroidism. The differences are hypothyroidism and hyperthyroidism. Okay. So the metabolic differences is that there is cold intolerance, decreased sweating, weight gain, decreased basal metabolic rate, decreased calorigenesis, hyponatremia, decreased free vital clearance, and everything opposite to this is in hyperthyroidism. So cold intolerance is there because there is decrease in basal metabolic rate, there is decrease in calorigenesis. Heat intolerance is there because there is increase in BMR, right? So there is heat intolerance, increase in sweating because the heat is increased, and also weight loss is there because metabolism is maximum, and there is increase in calorigenesis, and increased synthesis of sodium, potassium, adipase pump will lead to increased basal metabolic rate. So okay, let's talk about skin and hair. Skin, hair are dry and cool skin due to decreased blood flow. Coarse and brittle hair, diffuse alopecia, that is hair loss, that is in diffuse manner. Brittle nails, easily fragile nails, and puffy faces and generalized non-pitting edema, that is mixed edema, due to increased in GAGs in interstitial space. So that will increase to osmotic pressure, causing water retention. GAG is glycosaminoglycans. So increase in glycosaminoglycans cause mixed edema actually. Okay. In hyperthyroidism, warm, moist skin due to vasodilation occurs. Fine hair, onycholysis, petevial mixed edema, and Graves' disease can occur. So let's here see. This is onycholysis. The nail is trying to drop off, right? That is onycholysis. This is pretevial mixed edema in case of Graves' disease. Pretevial in tibia, right? That is in Graves' disease. There is periorbital edema in hypothyroidism. This is also due to increase in glycosaminoglycans secretion. And ophthalmopathy in Graves' disease, including periorbital edema, exophthalmos, lead lag or retraction, increase in sympathetic stimulation of superior tarsal muscle cause this lead lag or retraction, right? These are like ophthalmopathy is the classic feature of Graves' disease. We have to remember that. We will talk about that in detail in Graves' disease, okay? So in gastrointestinal, there is constipation due to decrease in GI motility, decrease in appetite. Like everything that is decreasing happens in hypothyroidism, everything that is increasing happens in hyperthyroidism. Obvious, it is very obvious, right? Hyperdefecation, diarrhea due to increase in GI motility, increased appetite happens in this case. So actually BMR increases, and also respiratory rate also increases, right? Because there is increased metabolic rate in cellular level, there are increased use of ATP, right? Since there is increased use of ATP, we should be respirating fast to provide oxygen to form more ATPs, right? So in musculoskeletal system, hypothyroid myopathy like proximal weakness, the increase in creatine kinase, carpal tunnel syndrome, mixed edema like a small lump rising on the surface of a muscle when struck with a hammer. That is, myoedema, okay. Myoedema, a small lump rising on the surface of a muscle when struck with a hammer. This is very interesting, right? So in thyrotoxic myopathy happens in hyperthyroidism, proximal weakness, normal CK. So if there is proximal weakness and increased CK, that is hypothyroidism. But if there is proximal weakness and normal CK, that is hyperthyroidism. Okay, osteoporosis or increased fracture rate. T3 stimulates osteoclast differentiation, increased in bone resorption, and release of calcium may also affect osteoblast. These are the reason. Okay, why osteoporosis happens in hyperthyroidism cases? Because T3, that is triiodothyronine hormone, it stimulates osteoclast differentiation, and osteoclast is the cell. These are the cells that eat up the bone, right? And increase in bone resorption and release of calcium may also affect osteoblasts. Okay, let's talk about reproductive findings. There is abnormal uterine bleeding, decreased libido. Libido is sex drive. There is decrease in libido, and infertility is a major finding. Abnormal uterine bleeding, gynecomastia, decreased libido, and infertility. This is almost similar in both cases. And in neuropsychiatric symptoms, there is hyperactivity, lethargy, fatigue, weakness, depressed mood, decreased reflexes like delayed or slow relaxing, right? And in neuropsychiatric syndromes in hyperthyroidism, there is hyperactivity, restlessness, anxiety, insomnia, fine tremors due to increased beta adrenergic activity, increased reflexes, brisk reflexes, right? That is what it happens. So in cardiovascular finding is the most important finding in both of the cases. You have to remember bradycardia, dyspnea, that is difficulty in breathing. That by Harrison's or Davidson's definition, dyspnea is the sudden uncomfortable urge to breathe, that is dyspnea. On exertion, that is increased workload, right? That is decreased cardiac output. That happens in this case. Tachycardia, palpitations is when you get aware of your one heartbeat. Tachycardia, increased heartbeat and rate of heartbeat. Obviously, dyspnea is difficulty breathing. Arrhythmia is irregular heartbeat like an atrial fibrillation. Chest pain, systolic hypertension due to increased number and sensitivity of beta adrenergic receptors, and increased expression of cardiac sarcolemmal adipase, and also decreased expression of phospholamban. So phospholamban actually helps in the muscle relaxation. So if there is decreased expression of phospholamban, obviously the contracted muscle will stay contracted for a longer time, right? So that is why it happens in here. So lab finding is increased TSS if primary, decrease in free T4, hypercholesterolemia due to decrease in LDL receptor expression. Hypercholesterolemia is a very much important finding in hypothyroidism. So in decrease in TSS if it is primary, increase in free T3 and T4, and like what actually happens is there is a axis, right? There is an axis. So actually TRH secretes TSH, and that stimulates the secretion of T3 and T4, right? So if there is already increased secretion of T3 and T4, that actually inhibits what? That inhibits TSH, right? So there is decrease in TSH. So in hyperthyroidism cases, there are increase in T3 and T4, but it inhibits the secretion of TSH because it is already increased. That is why TSH is decreased. That is the finding here. If it is a primary case, right? If it is a secondary case, if it is not the thyroid gland that is affecting, but if it is a pituitary gland that is affecting, then TSH is already decreased, and that will lead to decrease in T3 and T4, right? And that will lead to compensatory increase in TSH, and then a loop happens, and then T3 and T4 will then get increased. That is secondary cases, right? So decreased in LDL, SDL, and total cholesterol happens. There is hypocholesterolemia in hyperthyroidism, but in hypothyroidism there is hypercholesterolemia because there is decreased LDL receptor expression. LDL is low density lipoprotein. It actually, what happens is it brings the hepatic triglycerides into the peripheral tissues, right? That is why it happens in here, hypercholesterolemia. Okay, let's talk about the lesions that are associated with hypothyroidism. Okay, First one is Hashimoto's thyroiditis. It is autoimmune disease. It is chronic autoimmune thyroiditis. Most common cause of hypothyroidism in iodine. Most common cause of hypothyroidism in iodine sufficient regions, right? So in iodine insufficient regions, like in Himalayan regions, there is decreased iodine intake, right? In that cases also hypothyroidism happens. But in iodine sufficient regions, the most common cause of hypothyroidism is Hashimoto's thyroiditis. It is associated with HLA-DR3, differs by ethnicity. It increases the risk of primary thyroid lymphoma, typically diffuse large B-cell lymphoma. Okay. You have to remember this association right here. So HLA-DR3, it is a very important genetic association of Hashimoto's thyroiditis. The findings are moderately enlarged non-tender thyroid. It may be preceded by transient hyperthyroid state, that is hashitoxicosis due to follicular rupture and thyroid hormone release. Okay. In Hashimoto thyroiditis, what actually happens is there is degradation of this thyroid gland, right? So in initial regions, there are preformed thyroid hormones in these regions, right? So if there are preformed thyroid regions, thyroid hormone, and the cells are lysed, these preformed thyroid hormone molecules should release. So that release will cause transient increase in thyroid hormone, that is hashitoxicosis. But later on, when they got finished, that then lead to hypothyroidism in long term. That is what you have to remember. And serology is antithyroid peroxidase enzyme is positive, antimicrosomal, and also antithyroglobulin antibodies are positive. In histology, there are Hurthal cells, lymphoid aggregates with germinal centers. Let's see. There are Hurthal cells right here. These are Hurthal cells. Hurthal cells are characteristic features of what? Hashimoto's thyroiditis. And these lesions here, there are germinal centers with lymphocytes. It is so clear to read. And if you don't know how to read histology, I have made a separate video. In 35 minutes, you will be able to read any histopathology slide, so you can check it out. Okay. Postpartum thyroiditis, mild self-limited variant of Hashimoto thyroiditis arising less than 1 year after delivery. Okay. Postpartum thyroiditis, it is a subset of Hashimoto's thyroiditis. It happens in less than 1 year after delivery. The natural history is that hyperthyroidism within 3 months of birth will lead to hypothyroidism, will lead to recovery or euthyroid state. Okay. In subacute granulomatous thyroiditis, also called DeQuervain thyroiditis. Okay, this is very high yield. DeQuervain thyroiditis, you have to remember this term. It is usually a self-limited disease. Natural history is that transient hypothyroidism now will lead to euthyroid state, and then hypothyroidism, and then again euthyroid state. This is a very paradoxical pathway. There is transient hyperthyroidism, and then euthyroid state is achieved, then hypothyroidism occurs, and then again compensatory euthyroid state is achieved. That happens in subacute granulomatous thyroiditis. It is often preceded by viral infection. This is what you have to remember. If a patient comes with a history of viral infection and symptoms of hypothyroidism, then you have to suspect DeQuervain thyroiditis or subacute granulomatous thyroiditis. The findings are increase in erythrocytic sedimentation rate, jaw pain, and very tender thyroid. DeQuervain is associated with pain. Last, vein is pain, right? DeQuervain is associated with pain. Histology is granulomatous inflammation. You can see these are granulomatous inflammation in these regions here. You can see. And there is another term called renal thyroiditis. Let's talk about it. It is also called invasive fibrous thyroiditis. It may occur as part of IgG4 related disease spectrum. Example, autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. Aortitis is inflammation of the walls of aorta, right? So it can happen in renal thyroiditis. Hypothyroidism occurs in 1/3 of patients. Fibrosis may extend to local structures like trachea, esophagus, mimicking anaplastic carcinoma. The findings are slowly enlarging, hard, rock-like rock-like, fixed but non-tender thyroid. Okay, there is fixed, rock-like, rock hard thyroid gland, but it is non-tender. So that is the characteristic finding. And thyroid replaced by fibrous tissue and inflammatory infiltrate is there. Okay, here you can see these thyroid glands are getting replaced by these fibrosis right here. Okay, let's talk about congenital hypothyroidism. It is formally called cretinism, most commonly caused by thyroid dysgenesis, abnormal thyroid gland development. Example: agenesis, hypoplasia, ectopy. Agenesis is no formation of thyroid gland. Also, hypoplasia is decreased in mass, thyroid mass. Ectopy and dysharmonogenesis, abnormal thyroid hormone synthesis. Example: mutations in thyroid peroxidase enzyme in iodine sufficient regions. Okay. The findings are 6 P's in congenital hypothyroidism. Pot-bellied patient, pale, puffy-faced child. Okay. Pot-bellied, pale and puffy-faced child with protruding umbilicus, protuberant tongue, and poor brain development. These are the findings. Okay, 6 P's are the findings of congenital hypothyroidism. Pot-bellied, pale, puffy-faced child with protruding umbilicals, protuberant tongue, and poor brain development. There might be 2 figures here. This is before treatment figures, right? This is after treatment figures. So, in figure E, there is puffy face, right? Puffy face is due to edema. That is due to increase in glycosaminoglycans. This is after treatment. This is the face that actually was there. And in F cases, there is protruding tongue like this. Protruding tongue, right? And also poor brain development is there. Okay. The other causes are iodine deficiency, most common cause worldwide, typically presents with goiter. Actually, in not in well-developed countries, but in low and middle-income countries, it is the most common case of hypothyroidism. And also, reason for hypothyroidism: iodine excess, that is Wolff-Chaikoff effect, drugs like amiodarone, lithium, non-thyroidal illness syndrome, also called euthyroid 6 syndrome, in Wolff-Chaikoff effect also, and in decreased T3 with normal or decreased T4 and TSH in critically ill patients can cause hypothyroidism. Okay, here you can see this is the Wolff-Chaikoff effect. If there is increased iodine, that will lead to Wolff-Chaikoff effect. We will talk about Wolff-Chaikoff effect and Jord-Bestow's effect in biochemistry in detail. Okay, let's talk about the lesions associated with hyperthyroidism. So hyperthyroidism, they are associated with Graves' disease, toxic multinodular goiter, thyroid storm, which is thyroid emergency, and other causes, right? Then in Graves' disease, what actually happens is it is the most common cause of hypothyroidism. Thyroid stimulating immunoglobulin, TSI. TSI are the major markers of Graves' disease. Okay, thyroid stimulating immunoglobulin like IgG can cause transient neonatal hyperthyroidism, type 2 hypersensitivity. It stimulates TSH receptors in thyroid, hyperthyroidism, diffuse goiter, and also dermal fibroblasts are increased that causes pretibial myxedema. We have was the figure of pretibial myxedema here. This is the finding of Graves' disease. And then there is orbital fibroblast, that is Graves' orbitopathy. We have to treat with glucocorticoids. All the lesions that are associated with Graves' disease are due to fibroblasts actually, right? There are increased fibroblasts. Here you can see exophthalmos, there is a gaze, there is lead lag, lead retraction also. This is ophthalmopathy in the case of Graves' disease. So activation of T cells happens that causes lymphocytic infiltration of retroorbital space, and that will lead to increase in cytokines like TNF alpha, tumor necrosis factor, interferon gamma, and also that will lead to increase in fibroblast secretion by hydrophilic glycosaminoglycans that will lead to osmotic muscle swelling, muscle inflammation, and adipocyte count causing exophthalmos. This is the pathophysiology of exophthalmos. Activation of T cells, lymphocytic infiltration of retroorbital space, increase in cytokines, increase in fibroblast secretion of hydrophilic glycosaminoglycans, increase in muscle, osmotic muscle swelling, muscle inflammation, and adipocyte count that will lead to exophthalmos. So it often presents during stress, example, pregnancy, associated with HLA-DR3 and HLA-B8. Okay. Histology is tall, crowded, follicular epithelial cells, scalloped, colloid. You can see here, right? Scalloped is actually this kind of colloid is there. This is scalloped. Scalloped colloid is there here. You can see. Right? So that is the histological finding. Let's talk about toxic multinodular goiter. It is actually focal patches of hyperfunctioning hot nodules. You can see there. You can see hot nodules in scintigraphy. Cells distended with colloid working independently of TSS due to TSS receptor mutations in 60% of cases. Okay, there is TSS receptor mutation in 60% of cases, and it will increase release of T3 and T4 hot nodules. I have talked earlier. Hot nodules and radioactive iodine scanner scintigraphy. There is hyperfunctioning nodules visualized on, like it is very reddish orange color hot nodules are seen, and they are rarely malignant, right? In thyroidism, this is a thyroid emergency case. What actually happens is, this is very uncommon but serious complication that occurs when hyperthyroidism is incompletely treated or untreated, and then significantly worsens in the setting of acute stress such as infection, trauma, or surgery. This, like comorbidities, impact this region. So hyperthyroidism is incompletely treated or untreated, right? And also there is a setting of acute stress like infection, trauma, or surgery. So it presents with agitation, delirium, fever, diarrhea, coma, and tachyarrhythmia. Cause of death is the tachyarrhythmia is the cause of death. Okay, may see increase in liver function tests and treat with the 4 P's. 4 P's are the treatment right here. Beta blockers like propranolol, propylthiouracil, glucocorticoids where we use prednisolone, and potassium iodine, that is Lugol's iodine is used. Iodide load, that is decreased T4 synthesis, will lead to Wolff-Chaikoff effect again. T4 is thyroxine, right? So treatment is by 4P, propranolol, propylthiouracil, prednisolone, and potassium iodide, PP, right? There are 6 P's in here. In congenital hypothyroidism, that is for the symptoms, and there are 4 P's in thyroidism that are for the treatment, right? The other causes of hypothyroidism is exogenous thyrotoxicosis, as in excessive intake of thyroid hormone, suspect in patient trying to lose weight, ectopic thyroid production, as in stoma over eye, and contrast-induced thyroiditis, that is Jord-Bestow phenomenon. We will talk about that, these two effects, Jord-Bestow and Wolff-Chaikoff, in biochemistry. I have talked about it earlier. And drug-induced thyroiditis like amiodarone. The most common side effect of amiodarone that is used in arrhythmia cases is hyperthyroidism. Also increase in sodium, right? And lithium also. Okay. The causes of goiter are, there are 2 types of goiter actually, smooth or diffuse and nodular goiter. In a smooth or diffuse goiter, the causes are Graves' disease, Hashimoto thyroiditis, iodine deficiency, TSS secreting pituitary adenoma. And in nodular goiters, the causes are toxic multinodular goiter, thyroid adenoma, thyroid cancer, or thyroid cyst. Okay, let's talk about thyroid adenoma. So what are thyroid adenoma? They are benign lesions actually, benign solitary growth of the thyroid are thyroid adenoma. They are mostly non-functional, as cold, unradioactive iodine scan. So if in radioactive iodine scan, if they are cold, they are thyroid adenoma. But if they are hot nodules, that is a case of multinodular goiter, toxic multinodular goiter. So findings can be same. There can be nodules in both cases, but if they are cold in radioactive iodine scan or scintigraphy, then it is cold, that is, then it is thyroid adenoma, otherwise it is multinodular toxic goiter, right? So it can rarely cause hyperthyroidism by autonomous thyroid hormone production, that is hot or toxic. And also most common histology is follicular, as you can see here. There is absence of capsular or vascular invasion, unlike follicular carcinoma. The difference between follicular carcinoma and thyroid adenoma is there is absence of capsular and vascular invasion. Okay, let's talk about thyroid cancer. There are different types of thyroid cancer. That is the last topic for today. Okay, be patient. I hope your coffee is not finished yet. If it didn't turn cold. Okay, thyroid cancer. Let's do it. So typically diagnosed with fine needle aspiration, that is FNAC, diagnosed with FNAC, right? And it is treated with thyroidectomy, that is the resection of either the part of thyroid gland or entire thyroid gland, after which we will need a lifetime hormone replacement therapy. So the complications of surgery include hypocalcemia due to removal of parathyroid glands too, and transection of recurrent laryngeal nerve during ligation of inferior thyroid artery leads to dysphagia, that is difficulty in swallowing, and dysphonia, that is difficulty in speaking, causing hoarseness, right? In thyroidectomy, the most common, also in thyroidectomy and also in thyroid cancer, if it is not done thyroidectomy, in both cases, the most common risk factor is the compression or ligation or compression or litigation of recurrent laryngeal nerve that causes hoarseness of voice, and injury to the external bands of superior laryngeal nerve during ligation of superior thyroid vascular pedicle. It may lead to loss of tenor, usually noticeable in professional voice users. Okay, there are different types of thyroid cancers: papillary thyroid carcinoma, follicular carcinoma, medullary carcinoma, undifferentiated or anaplastic carcinoma. So out of this, papillary thyroid carcinoma is the most common and most important too. There are empty appearing nuclei with central clearing, that is called orphan NEI nuclei. Orphan NE, if you know what it is, or if you don't know, you can look at the Google pictures, right? There are orphan NEIs looking, and Samoma bodies are present. Nuclear groups like Papi and MoMA adapted orphan NE. This is mnemonics. Papi, that is papillary carcinoma, and MoMA, that is Samoma's bodies are present, adapted orphan NE, that is the characteristic nuclear features. Empty appearing nuclei with central clearing, that is orphan NEI nuclei are present in papillary carcinoma. There are different types of papillary carcinoma also. There are Tolsel variant, Hobnell variant. It is not mentioned here. We will talk about that in reliable sessions or lectures in our upcoming sessions. Okay, so there is increased risk of red PTC mutations, rearrangements, and BRAF mutations, childhood irradiation. If you don't know how to remember if they are proto-oncogenes or tumor suppressor genes, you can check it out in our channel, that there is a very common itsy bitsy spider mnemonics, and also twinkle twinkle little star mnemonics that will make it easier for you to remember almost all tumor suppressor genes and proto-oncogenes. And papillary carcinoma, it is most prevalent. Palpable lymph nodes are there. It has good prognosis. Okay. In follicular carcinoma, it also has good prognosis. It invades tumor capsule. Here you can see the orphan NEI, right? But visit Google, look at what actually orphan NE is, so you will be able to remember this histology in a better way. Okay, it invades tumor capsule and vasculature, unlike follicular adenoma, and uniform follicles are there. Figure you can see there is invasion, right? Okay. Hematogenous spread is common, and it is associated with VAS mutation and also PAXET PPAR gamma translocations. Okay, you have to remember this. This is a very high yield point here. PAXET PPAR gamma. I think it has been asked once or two times in USMLE Step 1 2. So this is very high yield. And fine needle aspiration cytology may not be able to distinguish between follicular adenoma and carcinoma, so we have to do the genetic cytology. Now in medullary carcinoma, they are from parafollicular C cells producing calcitonin, seeds of polygonal cells in an amyloid stroma which stains with Congo red. You can see this is Congo red staining. There is difference between Congo red staining and SNED staining. We have talked about it in how to read histopathology slides in our video. You can look at that. Associated with main 2A and 2B mutations, rate mutations, medullary carcinoma. In medullary carcinoma, we can remember like medullary carcinoma. So main 2 mutation is there. Red mutation, obviously. Okay. There is other type that is undifferentiated or anaplastic carcinoma. They are usually present in older patients. Presents with rapidly enlarging neck mass, compressive symptoms like dyspnea, dysphagia, hoarseness. It has a very poor prognosis. So undifferentiated or anaplastic carcinoma has a very poor prognosis and typically composed of pleomorphic cells with frequent mitosis. Right here you can see these all are mitotic figures here. This is very diffused, right? Here you can see, and it may arise de novo, that is new, out of nowhere, but most often arises from dedifferentiation of pre-existing follicular or papillary thyroid carcinoma. So that is how we finish our thyroid gland 2. We'll talk about parathyroid gland and other lesions in our upcoming lessons. So stay with us in our upcoming lectures. So stay with us. Thank you. If you are still here, subscribe and share for our channel growth. Thank you.